My name is Reis. I'm a Brazilian-trained ophthalmologist, and I currently practice full-scope optometry in Vancouver, British Columbia, Canada. Dry eye is a very complex disease with a range of signs and symptoms that need to be analyzed in a structured, organized way. So in our case, we use all quantifiable parameters that we can get our hands on, from tear osmolarity, patient's questionnaire, breakup time, corneal staining, meibography, and so on. And we implemented an algorithm that taps into studies such as the DIAGNOSE, and that allows us to leverage all that information and apply that into clinical day-to-day practice. Using algorithms, in my opinion, is important not only in dry eyes, but in every complex multifactorial disease because one, it helps you prevent errors and oversights, and two, it elevates patient care and improves clinical outcomes. I noticed that every doctor tries to treat dry eyes and diagnose it in a different way. And that issue stems from that wealth of information, the famous information overload that doctors have to deal with, the time constraints that we face on a day-to-day practice, and also patients refusing to undergo some extended testing and so on. So the way for me to tackle all of those issues was to implement a systematic approach to dry eye diagnosis and treatment to enhance patient outcomes and satisfaction. The dry eye algorithm starts with the most important part of it, which is a questionnaire. And in that one, patients can be classified as positive or negative. So on the left-hand side of the algorithm, you have the patients that told you on the questionnaire that they have symptoms of dry eyes. And those ones can be divided into two. Patients that tell you they have a symptom, and when you examine them on the slit lamp, they do have signs of dry eyes, and we'll talk about them later. And the patients that have symptoms, but when you look at them in the slit lamp, there's nothing to be seen. So those ones are considered neuropathic or preclinical dry eyes. So what does that mean? So the neuropathic dry eye patients are the ones that they don't have signs, they don't have symptoms, and they just have this excessive, exacerbated response that leads to the sensation of dry eyes. And those can be sent to a pain clinic, pain management, and also they benefit from hyaluronic acid eye drops and overnight gel. For the patients that you see no signs, no symptoms, but perhaps a slightly reduced tear breakup time that's still within range, but at the higher threshold, then those patients you can classify as preclinical dry eyes. And as we all know, dry eyes is a progressive chronic disease, so it's better to start treating those patients when it's early. Now, going back to the ones that have positive signs and positive symptoms. The ones that have positive signs and symptoms, in my personal private practice, I bring them back on another day, which means you don't have time to address their refraction issues, their dry eye issues, their cataracts, and so on. You have to have it done separately so you can follow the algorithm without feeling that your patient flow is suffering. So those patients come back to you, and I would strongly recommend that you perform at least tear osmolarity and some other measurable, quantifiable test, such as tear breakup time, SM tube, keratograph, or meibography. And meibography is actually quite important in this one because it helps to differentiate between aqueous deficiency, meibomian gland dysfunction, or evaporative dry eyes, or patients that have a mixed scenario. And then from there, you just follow the guidelines and you see what you can do for those patients.